Thank you for your introduction. Yes, my name is Taedong. I'm a neurologist from the National Health Insurance Service Ilsan Hospital. And today I'll be speaking about the medical treatment of carotid artery disease in patients with stroke. So here's today's outline. I'll be focusing on the current evidence and guideline-based recommendation for antithrombotics and lipid-lowering strategies with the considerations for both CAS and CEA. So carotid artery becomes increasingly common with age. It's rare under 50 with a prevalence of just 0.2%, but rises to about 7.5% in people over 80. Carotid artery accounts for about 20 to 25% of all ischemic strokes. Therefore, proper management of carotid artery disease is essential for stroke prevention. Moreover, the risk of recurrent ipsilateral stroke is especially high in the early period following a symptomatic event, reaching nearly 19% within 90 days. Let's look at the medical treatment for patients who do not undergo CAS or CEA. According to the 2023 ECVS guidelines, for patients with asymptomatic carotid stenosis over 50%, low-dose aspirin is recommended to reduce the risk of late myocardial infarction and other cardiovascular events. There are two studies supporting the current recommendation. The only randomized control trial was conducted in 1995. It included patients with cervical bruit and at least 50% stenosis on duplex ultrasonography. This study compared aspirin use with no treatment and found no significant difference in outcomes such as stroke, MI, or death. However, up to two-thirds of patients with asymptomatic carotid stenosis also have subclinical coronary artery disease. A systematic review of 17 observational studies, including patients with more than 50%, found that 63% of deaths were of cardiac origin. A meta-analysis of primary prevention trial showed that aspirin has been shown to reduce serious vascular events, particularly non-fatal myocardial infarction. Therefore, in patients with asymptomatic carotid stenosis greater than 50%, aspirin may still offer preventive benefits against cardiac disease. Moreover, in 2013, an asymptomatic carotid emboli study, which is a prospective observational study involving patients with more than 70% asymptomatic carotid stenosis over 26 centers worldwide, showed that the antiplatelet therapy significantly reduced the risk of stroke and cardiovascular deaths in these patients. There is currently no randomized control trial supporting long-term dual antiplatelet therapy in asymptomatic patients. However, there is one study that evaluated the combination of aspirin and low-dose rivaroxaban. The COMPASS trial, a randomized double-blinded placebo-controlled study published in 2018, showed that this combination led to a favorable trend in reducing a composite outcome of stroke, MI, and death without a significant increase in bleeding risk. Okay. So let's go on to symptomatic patients. This slide shows the 2023 ECSVS guidelines for symptomatic carotid stenosis. Although this may look a little complex, the overall strategy is similar to antiplatelet use in acute stroke setting. Dual antiplatelet therapy is recommended during the acute phase, typically about 3 weeks, followed by long-term monotherapy. For symptomatic carotid stenosis, regardless of the degree of stenosis, if CA or CAS is not planned, antiplatelet treatment can be guided by the strategies used in the CHANCE, POINT, and TALES trials. These trials excluded patients planned for CA or CAS, but still serves as a reference for those managed with medical therapy only. There are RCTs comparing dual antiplatelet and aspirin monotherapies in carotid stenosis patients. Though the primary focus was on spontaneous embolization detected by TCD, spontaneous embolization is an important predictor of increased stroke risk. In the RCT by Panel et al., patients receiving aspirin 4 weeks with either placebo or clopidogrel added 12 hours before the procedure. The dual antitherapy group had significantly fewer embolic signals during post-op TCD monitoring, only 0.1 odds ratio for more than 20 embolies. In the KOVAS trial, patients with symptomatic stenosis and microembolic signals were randomized to aspirin alone and aspirin plus clopidogrel. After 7 days, the dual antiplatelet group had a 39.8% relative risk reduction in persistent embolization on TCD. These results suggest that dual antiplatelet therapy is more effective in suppressing microembolization in patients with carotid stenosis. Let's go on for patients undergoing KOVAS. Yes, again, according to the 2023 ESVS guideline, aspirin plus clopidogrel is recommended for at least 4 weeks after carotid artery stenting, followed by lifelong monotherapy. Long-term dual antiplatelet therapy is not recommended due to bleeding risk and lack of additional benefit. However, the optimal duration of dual antiplatelet therapy after carotid artery stenting remains unclear, as there are no randomized control trials specifically designed to evaluate dual antiplatelet duration in this setting. The Society of Neurointerventional Surgery guideline currently recommends using dual antiplatelet for at least 3 months following carotid artery stenting. This recommendation is based on the fact that metallic stents used in carotid artery stenting are inherently thrombogenic, especially during the early post-procedure period. The risk of stent thrombosis remains until the stent becomes fully endothelialized, which typically occurs over a period of 28 to 96 days. A recent nationwide core study of over 12,000 patients who underwent carotid artery stenting compared short-term dual antiplatelet therapy of 3 to 6 months with longer duration beyond 6 months. The study found no significant difference in 12 months outcome, suggesting that dual antiplatelet for 3 to 6 months may be as effective as longer use after carotid artery stenting. Emergent carotid artery stenting is often performed, especially in the setting of acute ischemic stroke with tandem occlusions. Maintaining patency of the carotid artery is critical, but must be balanced against the risk of intracranial hemorrhage. Peri-procedural loading with GP2B3A inhibitors such as tirofiban or P2Y12 inhibitors has been shown to be more effective than aspirin alone in preventing subacute stent thrombosis without increasing the risk of intracranial hemorrhage. Typically, IV regimens are converted to oral agents within 24 hours. The SNIS guideline also recommends that it may be reasonable to give a loading dose of IV or oral GP2B3A or P2Y12 inhibitors during emergent KOVAS for stroke. Antithrombotic therapy becomes more challenging when KOVAS is performed in patients with atrial fibrillation. Current practice is largely adapted from the PCI guidelines in AFib patients. Typically, triple therapy, meaning oral anticoagulants plus dual antiplatelet therapy, is used during the peri-procedural period, usually up to 1 week. After that, dual therapy, oral anticoagulant plus a single antiplatelet agent is continued for up to 12 months, depending on ischemic and bleeding risk. Beyond 12 months, most patients are maintained on oral anticoagulate alone. Several studies have examined antithrombotics therapy in AFib patients after carotid artery stenting. They showed that using an oral anticoagulant, either alone or with antiplatelet therapy, reduced mortality. And in contrast, not using anticoagulation after emergent carotid artery stenting is associated with higher 90-day mortality. Triple therapy increases bleeding risk, while oral anticoagulant plus clopidogrel appears to be both effective and safer. Therefore, the SNIS guideline recommended that the duration of triple therapy, oral anticoagulant plus dual antiplatelet therapy, should be minimized or avoided altogether when possible. Instead, oral anticoagulation plus single antiplatelet therapy is preferred, depending on the patient's ischemic and bleeding risk. Cilostazol is a PDE inhibitor widely used in East Asia with antiplatelet, vasodilatory, and anti-inflammatory and lipid-lowering effects. A 2023 retrospective study compared cilostazol-based and clopidogrel-based dual antiplatelet therapy following carotid artery stenting. Patients were followed for at least 12 months. The cilostazol group had a similar risk of ischemic stroke, but with lower bleeding events, suggesting that cilostazol-based therapy may be a safe and effective option for patients undergoing carotid artery stenting. A recent randomized control trial evaluated the effect of adding cilostazol to antiplatelet therapy in patients undergoing CAS. Cilostazol was initiated 3 days prior to CAS and continued afterward. The study showed a significant reduction in instant restenosis within 2 years, especially beyond 30 days post-procedure in the cilostazol group compared to control. Next, we'll move on to the peri-procedural medical treatment strategies for patients undergoing carotid endarterectomy. To date, no randomized control trials have directly compared mono-antiplatelet therapy with dual antiplatelet therapy in this group. There is, however, one RCT from 1993 that compared aspirin with placebo. In this trial, patients received aspirin starting the night before CEA and continued for 6 months. Aspirin significantly reduced disabling stroke within 7 days. However, there was no difference in the instance of recurrent TIA, stroke, death at 6 months. So currently, we are still left with an important question. Should we be using aspirin alone or aspirin plus clopidogrel in the perioperative setting? Historically, surgeons have been cautious about using dual antiplatelet before CEA due to bleeding concerns. But practice has changed. In 2007, 52% of UK surgeons stopped clopidogrel while using DAPT before surgery. In 2012, only 24 did. A recent Danish study showed 50% of patients had CEA while on aspirin and clopidogrel. This showed growing confidence in safety of dual antiplatelet therapy before CEA. When choosing between monotherapy and dual antiplatelet before CEA, we must consider not just bleeding risk, but also stroke prevention. RCTs from the stroke trials showed that aspirin plus clopidogrel reduced early recurrent strokes and stroke during the 48 to 72 hours before surgery. Registry data also showed dual antiplatelet therapy lowers perioperative stroke risk, especially early thromboembolic events after CEA. The main bleeding concern after CEA is neck hematoma. The VSGNE registry found no significant increase in neck hematoma re-exploration with dual antiplatelet therapy. However, a meta-analysis showed a slightly higher major bleeding risk with dual antiplatelet therapy. So while dual antiplatelet offers stroke prevention benefits, it may carry a small bleeding risk. So clinical judgment is essential for tailored therapy. So for patients scheduled for CEA, the 2023 ECVS guideline recommends starting both aspirin and clopidogrel early. Aspirin is stopped on the day of surgery, while clopidogrel is continued post-operatively. Next, let's talk about lipid-lowering agents in patients with carotid artery stenosis. Statins may play a role not only in lowering LDL cholesterol, but also in stabilizing atherosclerotic plaques and reducing cardiovascular risk. The 2021 AHA guidelines recommends high-dose statin therapy with a goal of reducing LDL cholesterol to below 70 milligram per deciliter. If this goal is not achieved, additional ezetimibe or PCSK9 inhibitor should be considered. The Korean guideline is largely similar, except that the patients at very high cardiovascular risk and LDL target of less than 55 should be considered. The 2019 European guidelines are more aggressive in that patients with clinical atherosclerotic cardiovascular disease should be targeted below 55 and recurrent ones with below 40. Lastly, I would like to briefly introduce some recent findings regarding the PCSK9 inhibitors. The SLICE CA study is a very recent trial published in 2025. It evaluated the effect of evolocumab and carotid plaque characteristics, particularly the lipid-rich necrotic core, in asymptomatic but high-risk patients with carotid artery stenosis. The primary outcome was assessed using MRI imaging to evaluate the change in plaque composition. As expected, LDL cholesterol levels were much more reduced in the evolocumab group compared with the control. In the evolocumab group, the lipid-rich necrotic core volume decreased by 8.5 square millimeters, whereas it increased by 64.9 square millimeters in the usual care group. Although intraplaque hemorrhage volume did not decrease with the evolocumab, it showed a tendency to increase in the usual care group. Lipid volume was also reduced in the evolocumab group. Thus, in addition to lowering LDL, PCSK9 inhibitors may also have beneficial effect on the characteristics of atherosclerotic plaque. So this is the summary of my medical in patients not undergoing CA or CAS. In asymptomatic patients with over 50%, aspirin alone is recommended. In symptomatic cases, short-term dual antiplatelet to 21 to 90 days, and then followed by mono antiplatelet therapy. Low-dose rivaroxaban plus aspirin may be considered in selected high-risk patients. And after CAS, in elective cases, dual antiplatelets are recommended for over 4 weeks, typically 3 to 6 months, followed by lifelong monotherapy. In emergent cases, peri-procedure use of GP2B3A inhibitors or P2Y12 inhibitors is recommended. Those with atrial fibrillation, peri-procedural triple therapy, followed by dual antiplatelet, then oral anticoagulation alone is recommended. After CEA, pre-op dual antiplatelet may reduce perioperative stroke risk. Bleeding risk should be considered. Post-op transition to mono therapy is recommended. Lipid-lowering therapy is essential for carotid artery stenosis patients, and high-intensity statins are recommended in all patients. LDL target are as shown below, and if the targets are not reached, consideration for ezetimibe and PCSK9 inhibitors is needed. Thank you very much.